Now let's move to personalized medicine. So what is personalized medicine? It is defined as a treatment model or treatment regime that is designed specifically to a group of patients or to an individual based on the existing information, including the genetic information. So you can see in the picture there are a lot of ethnics and races. So we, based on the genetic information that we have from these patients, then or based on the ethnics or race, then we can tailor the treatment regime or treatment therapy uh, specific to that race or ethnic. So what questions lead to personalized medicine? Why do we want to have personalized medicine? Medicine is personal. We are all different. Some of our differences translate into how we react to drugs as individuals. And this is why personalized medicine is important to everyone. So why does someone need twice the standard dose to be effective? Why does this drug work for you but not for me? Why do I have side effects and you don't? Why do some people get cancer and others don't? And why is anecdotal information irrelevant to your own health and treatment? So these are the questions that lead to personalized medicine. Then how can the knowledge we obtain from sequencing our DNA help in the control of disease? What hypotheses can you come up with in applying the data obtained from sequencing our DNA? And you can read the rest of it. So these are the questions that you should ask yourself when you want to do pharmacogenetics. There is an emerging goal among translational scientists to make medical practice more personalized. Pharmacogenetics is an important step towards the goal. The effects of this movement are seen in many aspects of society. So overall, your DNA affects your response to drugs. Okay, it depends on your DNA. So your DNA will determine whether the drug is safe or effective, or safe but not effective, or unsafe and not effective, or unsafe but effective. So your DNA will play the role to determine which group you will fall in. And then also the variability of disease also contributes to the personalized medicine. For example, leukemia and lymphoma. In 1950, these diseases are just regarded or are just referred as disease of blood. So anything leukemia or lymphoma is just considered as disease of the blood. But until 1960, scientists have divided the disease of the blood into leukemia and lymphoma. And in 1970, further divided leukemia into chronic, acute, and pre-leukemia. And then for lymphoma, indolent lymphoma and aggressive lymphoma. And then by 2007, there have been 38 leukemia types that have been identified and 51 lymphomas identified. So by knowing the different disease, we can actually personalize the medicine given. Compared to 1950s, so these two diseases are just regarded as disease of the blood. So maybe only there are one or two drugs that are targeting for the disease of the blood. But once you know the different types of diseases, then you can specifically tackle the disease using a specific drug. And that's why in the 1950, the 5-year survival rate is about 0%, because the drug given may not even be beneficial for the condition. Okay, and then the survival rate increases up to 70% in parallel to the identification of many types of leukemia and lymphoma. So the goal of personalized medicine is to know the right dose, the right drug, the right indication, the right patient, and the right time. So these are the goals of personalized medicine. Okay. So this is an example of purine analogs, a case study in pharmacogenetics. So purine analog, the analogs are chemical structures that are similar to purine. So 6-mercaptopurine, 6-thioguanine, and azathioprine, these are all purine analogs. 6-mercaptopurine is used to treat lymphoblastic leukemia, autoimmune disease, inflammatory bowel disease, and also after transplant. It interferes with nucleic acid synthesis and therapeutic index limited by myelosuppression, a treatment limited by immune suppression side effect. So this is the chemical structure of 6-MP and 6-thioguanine and azathioprine. So the metabolism of 6-mercaptopurine from azathioprine then metabolized into 6-mercaptopurine, and then 6-MP is metabolized by TPMT into 6-methyl-mercaptopurine and also by XO into oxidized metabolites, and 6-MP is also metabolized into 6-thioguanine nucleotides. Individuals respond differently to the anti-leukemia drug 6-MP. Most people metabolize the drug quickly. Doses need to be high enough to treat leukemia and prevent relapses. However, others metabolize the drug slowly and need lower doses to avoid toxic side effects of the drug. And a small portion of people metabolize the drug so poorly that its effects can be fatal. So the diversity in responses is due to variations in the gene for an enzyme called TPMT or thiopurine methyltransferase. So this is one of the metabolizing enzyme of 6-mercaptopurine. So for those people that metabolize the drug quickly, they have the normal alleles, and then the ones that metabolize the drug slowly are the ones that have heterozygous allele, the mutant and also normal one. And then the people that metabolize the drug so poorly are the ones with both mutant alleles. So after a simple blood test, individuals can be given doses of medication that are tailored to their genetic profile. So in the case of this patient, then you can give lower dose of 6-mercaptopurine. So the TPMT activity and personalized dosage. So if you don't have a prior knowledge about the genetics of the patient, you would prescribe 6-mercaptopurine at a conventional dosing, whether it has mutant alleles or wild type mutant alleles or wild type alleles. You would give the same concentration of the drug or the same dose of the drug to all patients. However, after you do the genotyping, then you would know that particular patients have star 1, which is the normal, and then star 2 a variation, and star 3A 3C also variation. So once you know this, then you can tailor the dosage to be given to these kinds of to these different phenotypes. Okay, so for mutant alleles, you would lower down the dose very low, and then wild type mutant is slightly lower than the wild type. And then if you see the activity of TPMT itself in these three phenotypes, the normal, and then the heterozygous, and also the mutant. So you can see the activity of TPMT is very low in mutant individuals uh, com- compared to wild type and mutant, and then wild type has the highest TPMT activity.